coronavirus disease, or COVID-19, has impacted all of our lives and will have an everlasting effect far beyond its devastating human toll and suffering that we see today. In this presentation, entitled COVID-19, an update for our healthcare professionals, I will attempt to highlight and explain important epidemiological concepts that will assist our healthcare professionals better understand as well as provide timely answers to specific questions surrounding this pandemic. I will try to address relevant concerns, parse facts from fiction, and put forth suggestions for an expanded role for our profession that hopefully will benefit not only our patients, but our communities at large. With that in mind, the goals for this presentations are to explain and clarify information and data we hear and read about the COVID pandemic, address relevant concerns as well as help to parse facts from fiction, prepare our healthcare professionals to assist both patients and community in need of reassurance. Please keep in mind that the science and information about COVID-19 is evolving very rapidly. This presentation, recorded on April 3rd, 2020, is therefore time sensitive and should be viewed accordingly. Public health emergencies are scary, and not everyone is going to have the same response to these type of occurrences. Very often we will see emotional responses that we need to be able to balance with scientific-based facts and rationale. Hopefully this is what I will be able to provide you with in this presentation, the facts as well as the rationale, how we're going to be able to move forward as a profession. So what can we do as healthcare professionals? Well, we are and can become even more a trusted resource or source for health information for our patients and our communities. Counter misconceptions and misinformation by separating facts from fiction. Share personal protective equipment with those who care for affected patients. Provide appropriate and safe care for our patients, as well as be responsive to our co-workers' concerns and fears. Not everyone is going to have the same response to such an occurrence as this pandemic, and we have to recognize that sometimes the responses from our co-workers may not be the same as they are for all and everyone else. We can also maybe in the future look at dental clinic as a site for testing. Testing is a key in order to mitigate the progression of this disease, meaning can we provide more sites for testings in order to test more patients, in order to get a better handle on how this disease is progressing and how we can identify individuals in need of care. Maybe we can also use our clinics for mass vaccinations in the future when the vaccines become available. We obviously have both the facilities and expertise to be able to provide such a strategy to help mitigate the progression of this pandemic. So let's try to focus on a couple of definitions that are being thrown around quite a lot today. First of all, what is an epidemic? The occurrence or more cases of disease that can be expected in a given area or among a specific group of people over a particular period of time. This occurrence of disease and individuals are usually contained within a very specific area and does not progress beyond those specific areas. In this slide here, I can show some outbreaks that happen in 3 different states in the United States, Washington, Oregon, and California, and it's an epidemic because it doesn't progress beyond these contained areas. A pandemic, on the other hand, is an epidemic occurring over a very wide area, several countries or continents, and usually affecting a large proportion of the population. Examples of previous pandemics are cholera, AIDS, pandemic influenza, SARS, and now COVID-19, obviously. It might be very helpful to look at a very short timeline of COVID-19. On December 26, 4 unusual cases of pneumonia were noticed in Wuhan, China. The doctor who recognized these unusual cases reported the cases to his local CDC, Centers for Disease Control and Prevention. 2 to 3 days later, 3 additional cases were discovered, and on December 31st, clusters of 41 patients with pneumonia, all associated with the Wuhan seafood wholesale market in Wuhan, Hubei province in China, were recognized, and China at that point in time alerted the World Health Organization, WHO. On January 7th, the Chinese authorities had identified this new coronavirus that apparently was responsible for these outbreaks. 4 days later, China reports the first fatality. 4 days after that, the first case outside of China. And a week later, other countries, including the US, confirmed more cases. 3 days later, on January 23rd, the Chinese authority instituted mass quarantine in the Hubei province. On January 30th, WHO declares a global health emergency. On January 31st, more international restrictions were enforced all over the world. In the US, at that time, there were restricted travels specifically from China. And on February 2nd, first reported fatalities outside of China that occurred in the Philippines. On March 31st, at a press conference at the WHO headquarters, the Director General of the World Health Organization made the following statement. There are no more than 118,000 cases in 114 countries, and 4,291 people have lost their lives. We have never before seen a pandemic sparked by coronavirus. This is the first pandemic caused by coronavirus. So on March 31st, WHO declared COVID-19 a pandemic. So let's look at some more of the vocabularies or glossaries that we see during a pandemic. And they are important to understand, and obviously not only understand, but the implications of them as well. Quarantine restricts movements and contacts of an individual without signs or symptoms of the disease. Mass quarantine that occurred, for example, in the Hubei province in China was a quarantine of over 60 million individuals. Isolation restricts movements and contacts of an individual with signs or symptoms of the disease. So this is the big difference. The quarantine are individuals without signs or symptoms of disease. Isolation are instituted for individuals with signs or symptoms of disease. So quarantine, individuals that we might perceive or maybe think might be infected, and we keep them out of the general population in order to be sure that they are not infectious or infected. And isolation, those are cases that we already know are infected, and we isolate them in order to prevent them from infecting more individuals, as well as provide care for those individuals. Herd immunity is a resistance to the spread of virus due to increased immunity among the population. Flattening the curve depicts measures to slow the progression of the epidemic. And I will talk more about these concepts a little bit later in this presentation. Lockdown, shelter in place, extreme measures to diminish contact between individuals in a population. At the present time, it's estimated that more than 50% of the world population, estimated 4 billion people, are under lockdown. Social distancing. It's a strategy in order to prevent more infections between individuals, and it's defined as a distance between individuals that will mitigate aerosol transmission of a virus. In Europe, it's around 1 meter, 3 feet. In the United States, it's 6 feet or 2 meters. R0 or R0 is the reproduction number of a virus, or the expected number of individuals being infected by an infected individual. For example, an R0 of 1 suggests that the infection will start spreading. Growth rate changes in the new cases as a rate of previous cases, and I will show you more about that in a couple of slides as well. Case fatality rate, the percentage of someone with a disease that will eventually die from the infection. Now, it's important to realize that the case fatality rate is very easy to calculate. You take the number of people who have died and you divide it by the total number of people diagnosed with the disease. But obviously, as we don't know how many people actually have the disease today because we haven't tested everyone, therefore the case fatality rate that you hear might actually go up or even go down, obviously. But we have to differentiate the case fatality rate, where again we are looking at individuals with a diagnosis of a disease, and differentiate it from something called infection fatality rate. It's similar to the case fatality rate, but infection fatality rate are the number of deaths from a disease divided by the total number of cases. And obviously that could be either estimated or actually be tested. The attack rate is another concept that people are talking about. The attack rate is the number of new cases of disease during a specific time interval as a proportion of a population at the start of the time of the interval. The secondary attack rate is also something we hear a lot about. These are the number of new cases among contacts as a proportion of total number of contacts. So it's really the secondary attack rate that people are really talking about when they talk about how infectious this disease is and how it's going to progress and so on and so forth. So attack rate, secondary attack rate, two important concepts when it comes to understanding the progression of the disease or the pandemic in this case. Point prevalence, on the other hand, is the number of cases as a ratio of the population at the same point in time. It doesn't talk about how it's going to progress or what happened in the past. The only thing it will tell you, it will give you a snapshot in time on how many people are infected at the present time. Now, number of current cases is also based obviously on if we have appropriate and relevant testing of everyone in the population. That point prevalence can change depending on how we utilize testing in the future. SARS-CoV-2 or SARS-CoV-2 is the scientific name of the virus that's causing this pandemic, and SARS stands for severe acute respiratory syndrome. COVID-19 is a disease caused by this virus, and this virus belongs to the coronavirus family. This is a common virus that you find in the animal kingdom, but sometimes we see outbreaks in the communities among humans, and the two most immediate ones that comes to mind are the 2003 SARS outbreak that also apparently started in China, as well as MERS, which is the Middle Eastern respiratory syndrome that occurred in the Middle East in 2012. A zoonotic disease is an illness that originates from animals and then somehow infects humans. I'm going to speak a little bit more about that in the future as well. Modes of transmission, how virus spreads from one person to another, something else I'm going to talk a little bit more about. And then a technique that we use to look for the genetic signature of virus is something called reverse transcription polymerase chain reaction. Technically, what that technique is that we can actually identify the genetic signature of a virus. Ventilator, a machine that moves air in and out of the lungs when patients cannot or have trouble breathing. Personal protective equipment, such as masks, gloves, face shields that keep our healthcare workers from being exposed to a pathogen, something we are very aware of obviously in dentistry. Respirators is a type of face mask that seals around the mouth and filters out particles from the air before they breathe in. For example, an N95 respirator will filter out 95% of very small, less than 0.3 micron or micrometers or larger particles. A surgical mask, on the other hand, is a loose-fitting mask that don't filter out as many particles as a respirator. Now, there are different types of respirators, and we see different ones in the United States, in Europe, and other places in the world. Just to give you a little bit of idea of what kind of names they're being given. So all of them are really filtering phase pieces, or FFP. So in Europe, we talk about FFP1 and P1. And those masks, they remove 80% of all particles that are 0.3 micrometers diameter or larger. And FFP2 and P2 will filter out at least 94% of these particles. And then N95, as I mentioned, will filter out at least 95%. And then it goes up to an N99 and FFP3 that will filter out 99%, and there's even a P3 and 100 available as well. Now these are in very short demand, and there is a controversy right now considering who should wear these masks, face masks and respirators, and I will talk more about that in another couple of slides as well. Something else that we hear a lot about are confirmed cases, recovered cases, active cases, and fatal cases. And there are some very good websites where you can find a lot of this information about how many people are infected, how many people have recovered, and how many people have succumbed to this pandemic. those two websites that you see here on the slide are the ones I usually use when I give presentations on this subject. The first one comes from the Johns Hopkins University. The other one is the Worldometers, where you can get a lot of the information specifically about this virus. Now, the number of cases and recovered cases and active and fatal cases is not an issue of morbid fascination. It's more that we need to look at these numbers because they will change over time, and it's the changes that we should pay attention to. As of April 3rd, we have now more than 1 million reported cases and over 60,000 deaths, unfortunately. Now, looking at how these cases, the confirmed cases versus total confirmed death, we will see different trends. There are many different ways of looking at a pandemic. And the slide you see here are from data from the European Centre for Disease Control and Prevention. On the y-axis, you have the total confirmed death due to COVID-19. And on the x-axis, you have the total confirmed cases of COVID-19. And you will see these diagonal lines that go from the lower left corner up to the upper right corner. And it's a ratio of how many patients that have been diagnosed with COVID that have also perished, unfortunately. And you will see there's a great disparity or discrepancy or differences between different countries. In some countries, such as Italy, you have up to 10% of people who have been diagnosed are dying. In other countries, for example, Germany, it's only around 0.8%. We don't really know what the exact case fatality rate is, of course, but it's estimated to be maybe between around 1 to 2%, depending on where you live in the world. What is flattening the curve? Well, during the peak of the epidemic, the capacity of the healthcare system is such that it cannot take care of all the cases that are in need of care. So when the disease is progressing, if we can sort of flatten this curve, meaning can we get this curve to flatten such a way that we can actually have the capacity of the healthcare system being able to take care of all the individuals in need of care. At the present time, we are not in this state, not in Europe and not in the United States. Well, I shouldn't say Europe as a whole, because there are countries such as Germany, for example, that have enough beds, they have enough ventilators, so on and so forth. But other countries such as Spain, such as Italy, they don't have the capacity right now. So flattening the curve is very specific for specific countries and regions as well. Now we can change the capacity, obviously, in order to be able to flatten the curve. It depends, for instance, on the number of doctors, nurses, hospital beds, ICU, ventilators, so on and so forth. If we have enough, we can flatten the curve, and if we don't have enough, we haven't been able to flatten the curve yet. Hopefully in the end, though, we will not talk about flattening the curve. Hopefully in the end we'll talk about crushing this curve. Well, that's obviously a desired outcome of any type of pandemic. What about R0 or R0? I mentioned it before. Well, R0 or R0 will give you an estimate, each case on average, of an infected individual giving the disease to someone else. So for instance, you're going to see growth of this pandemic if R0 is above 1, because that means that every infected individual will infect someone else. If R0 goes below 1, well, then we're going to see slower progression of the disease. It's possible to calculate R0 as a product, meaning we multiply the duration, opportunity, transmission probability, and susceptibility. Of course, if we can change any of those variables, the duration, opportunity, transmission probability, susceptibility, we will be able to impact greatly on the progression of the disease. So what is the duration? Simply how long someone is infectious. And it depends on what disease we're talking about. For instance, if you talk about influenza, it's a very short period of time someone is infected, but there's some others that we are infected and infectious for a much longer period of time. Opportunity, that's a measure of how many people you come in contact with for every day that you are infectious. With someone like the flu, you're not infectious very long, but a lot of your interaction could potentially spread it. Transmission probability, or mode of transmission, this is a measure of the chance the infection will get across during an interaction, coughing, sneezing, and so on and so forth. Susceptibility is an individual's susceptibility to be infected, which can be affected obviously by vaccination or even immune status. The R naught for the flu is estimated to be approximately 1.28, and for SARS it's around 2 to 3. This is an estimate for SARS-CoV-2 that has been validated in a lot of different countries, by the way. So that number might be right, but obviously, as I mentioned earlier in this presentation, new data is coming out all the time, and we have to be very, very careful to use the old data in order to predict the disease in the future. Now, I'm going to show you a little bit how to measure the exponential growth of an epidemic. It may look a little bit complicated, but it's actually pretty easy. So N subscript D are the number of cases on a given day. E, average number of individuals someone infected is exposed to each day. And P is the probability that each of these exposure from this infected individual is becoming an infection. So the change in the new number of cases on a given day is the product of E, average number of individuals someone infected is exposed to each day, times the probability of each exposure becoming an infection, times the number of cases that were documented the previous day. If I look at the next day, meaning delta N D plus 1 subscript, then we have the expression for delta N D that I showed you in the previous expression, and we just add the new number of cases that we had the previous day. And then we're going to be able to see a growth of this pandemic. Now, we can explain this, we can change this expression to look a little bit different. And there is an advantage of doing this, obviously. If you look at this part of the expression here, 1 plus E times P, and let's say, for example, this is 1.19, it's very similar to accumulated interest. For example, if you have $100 that you put in the bank and you get 5% interest, after a year you have $105. The next year, with 5% interest, you don't have $110 because now the 5% is based on 105 rather than hundreds. So the second year you have $110.25. The year after that, you have $115.76. So you can see there's accumulation here where the interest is based on what it was the previous year and not only on the initial sum of money you put in the bank. And here's the same thing. For example, if this expression here is 1.19, 1.19, after 31 days, meaning you take it up to the power of 31, it's meaning you are getting interest every day, and you multiply this with the initial number of cases. In this case, I used the number 21,000. You will have 4.6 million people. If we can reduce this number to 1.15 after 31 days, you will have 1.6 million people approximately. And if we can reduce the number to 0.05, then after 31 days, you will have around 95,000 cases. So obviously, if we can actually change the E, the average number of individuals someone infected is exposed to each day, for instance by social distancing, or the probability of each exposure becoming an infection, meaning can we actually have individuals that become immune by vaccination, well then obviously we're going to be able to change this number to be lower, and we see slow down on progression. A very good source for understanding this a little bit better is the YouTube video that I have shown here in the lower left corner. I've taken a lot of the information from that YouTube presentation. Go in and take a look at that one. It's very, very informative. So if I look at the exponential growth here, we usually measure it or express it as a logistic curve. And this logistic curve is based on two parameters. One is the changes in the cases that we see during a day, and we divide that by the new cases of the previous day, and this is called the growth rate. Now, as you can see here, I put in something called the inflection point, meaning up to that point we're going to have more cases and the pandemic is going to continue to grow. If we come beyond this inflection point, then the pandemic is slowing down, we have less cases, it's slowing down, and eventually hopefully it's going to level out, as you see on the top of this curve. Let me give you a couple of examples here. Let's say, for example, that we have on March 3rd, 12,742 cases, on March 4th, 14,901 cases, March 5th, 17,865 cases, March 6th, 21,395 cases, and the next day 25,454 cases. You will see the change here, and I'm looking at the last 3 dates, March 5, March 6, and the day after, or whatever date we want to have afterwards. We will see that the change between March 5th and 6th was 3,530 cases, and March 6th to the next time we measure it, let's say it was March 7, it's 4,059. Now the ratio between those two is 1.15, as you can see here on the right hand side. So it's more than 1, which means we have actually a growth rate of more than 1, which means we're still on the upward trend of this logistic curve. On the other hand, if the changes between March 5th and March 6th and March 6th and the next day was similar, meaning we had only 3,530 new cases, if I divide those two numbers, we have a growth factor of 1, and now I have reached the inflection point. What we want to get to, obviously, is that we're going to have less cases the next day. So here you have 3,530 cases and then 2,824 cases. Now the growth factor is 0.8. We are now on the upward trend. We are now on the upper part of the logistic curve, meaning we are slowing down the progression of the disease. There are less people getting infected every single day. And this is where we want to get to. Unfortunately, in most countries, we haven't reached that point yet. So what is a zoonotic disease? Well, zoonotic disease, as I mentioned, comes from a reservoir of viruses among animals. In this case, we think that, we know probably very accurately today, that the virus, the SARS-CoV-2, originated among bats. These bats then infected another animal, pangolin most probably, and these two animals usually don't come in contact with each other, but in these open air markets where you have live animals, these connections between different type of species of animals will enable the virus to go from one species of an animal to another species of animal. If you then have also human viruses in the equation, you will have a reassortment of the virus. Now you can also have direct connection between the coronavirus, in this case, into humans. But as soon as the human gets infected with this virus that they don't really have any immunity to at the present time, they will continue to be infected and infectious and can then spread it to others. And that's usually how we see these zoonotic diseases being spread. How are they being spread? Well, we talk a lot about aerosol transmission. Aerosol is an interesting concept because we are not very good at defining it. Some people say aerosol transmission is suspension in air of particles small enough that they remain airborne for a prolonged period of time. Others say, well, aerosol is any generated droplets, doesn't matter how big or small it is, and these droplets, they can fall to the ground immediately. It's also aerosol. So WHO and CDC and other agencies, they make a little differentiation, what called small droplets and large droplets. Large droplets are 5 micrometers or microns and above, while smaller droplets are below 5 or below 3, depending on what definition you're using. Those are called small droplets. So why it's important to know the difference? Well, first of all, the amount of time these droplets are suspended in air varies greatly depending on the size. For instance, if the size is 100 micrometers, it probably only stays in the air for around 10 seconds. On the other hand, if it's below 3 microns, it may not settle for a long period of time, could be up to 2 to 3 hours. Another differentiation is that large droplets will not settle in the lower respiratory tract, while small droplets settle in the lower respiratory tract. And that's exactly what we see now with COVID-19, by the way. But as I mentioned before, there's some controversies surrounding this transmission through aerosol. This was an article that was published in 2019, actually. Look at, it is unknown whether small droplet or large droplet aerosol are the modes of transmission of these viruses. And the viruses they looked at that time was MERS, which is the Middle Eastern Respiratory Syndrome, also, as I mentioned before, coronavirus, and SARS. Well, we probably know more or less today that transmission occurred through individual, through person-to-person contact, through sneezing, coughing, and spit. The question always comes up is it enough to exhale, like you exhale or you talk? Is that enough to make the virus hang around enough in the air in order to infect someone else? And we don't have a real answer to that yet, of course. But there have been some studies that show the viability of the virus. This is a letter to the editor published on March 17th in New England Journal of Medicine. And these researchers, they looked at SARS-CoV-2, the plausibility of fomite transmission by looking at both in aerosol and fomites to see how long the virus could be viable. And what they found was the following. This new virus was viable up to 72 hours after being placed on stainless steel and plastic. It was viable up to 4 hours after being placed on copper, 24 hours after being put on cardboards, and in aerosol for 3 hours. Now don't forget, we talk about the virus itself and not the droplet in which it really resides. So we have to take these numbers for what they are, meaning the virus itself, but can we actually translate this pragmatically into clinical setting? And that's unclear. But it's interesting because if you look at the appendix of this letter, you can actually see the methodology that these researchers used in order to come up with these conclusions. And if you look at the top row that I've highlighted here, if you look at aerosol, you will see that the viability of this virus, the COVID-19 virus, and the SARS-CoV-1, meaning the SARS virus, the viability in aerosol are very similar. Actually, SARS-CoV-1 remained aerosolized and viable for a longer period of time than the COVID-19. Now, we know pretty well how SARS-CoV-1 was transmitted, meaning it did not hang around in the air for hours. It was transmitted from person to person with droplets. And looking at this data here, or these data here, gives me at least some reassurance that most probably the COVID-19 is transmitted the same way. So our concern should be the droplets. Now, the problem with the transmission is that most of the studies on transmission of droplets was done in the 1930s. Today, we start to see a little bit better data. If you look at this on the right side of the slide here, you will see a picture of what they call the multi-phase turbulent gas cloud from a human sneeze. This was published in JAMA in the Journal of American Medical Association a couple of days ago. And what you can see here, which is pretty disturbing actually, is that if you look at the particles being expressed by this individual sneezing, these particles can reach a distance of 7 to 8 meters or 21 to 24 feet. So looking at the social distancing of 6 feet, 2 meters, or 3 feet, 1 meter, is that enough? Well, most probably it is. So we have to be very careful, obviously, to be able, when we try to extrapolate laboratory data such as these from clinical or real-life data. But we have to also be aware of that new data probably will be available when it comes to specifically transmission and aerosol, which to us, obviously in dentistry, is a great concern. And I'll show you some data why we are so concerned about it. This is a graphic presentation, was actually published in the New York Times a couple of days ago. And what you can see here on the y-axis is the exposure to the disease that goes from 0 to 100. And then the x-axis, you see proximity to others that goes from 0 to 100. And if you look at the upper right corner, you will see that dental hygienists actually had exposure to disease of to 100 and physical proximity of 100, meaning they actually had the highest chance of being exposed to people with the disease because of the exposure, as well through aerosol, and because of how close they were to the individuals. Even if you look at other oral healthcare professionals, for instance, dentists, general dentists, the exposure to disease was around 95, physical proximity 99. Or a maxillofacial surgeon, almost as close as hygienist, 99 and 99. And then dental assistants also very close. Exposure to disease 96 and physical proximity obviously 99. So there's no question about it that we in our profession are at very, very high risk when it comes to transmission as well as exposure to this disease. It's often very helpful to retrospectively look at what have happened in some of these outbreaks that we have more information about. And this is an article that was published looking specifically from the data from China. There were over 72,000 cases. That was as of February 11th, 2020. They looked at 44,672 confirmed cases. There are suspected cases, there are diagnosed cases, in asymptomatic cases. I will go a little bit more into detail about the age distribution, the spectrum of disease, and the case fatality rate in another couple of slides. But if you look at the lower left side, healthcare personnel, this is interesting. Because of the 44,672 confirmed cases, 3.8%, or 1,716, were actually healthcare professionals. Out of those, 63,000 were in Wuhan, where the disease was initially recognized. And close to 15% of those cases were classified as severe or critical, and unfortunately 5 deaths at that time. One of those deaths were the individual, the physician that originated the initial report of this disease. It's interesting to look at the gender differentiation between confirmed cases between men and women. It's very similar, meaning it's around 50-50 when it comes to both men and women. On the other hand, more men died from the virus in this cohort than women. It's unclear if it's a gender-specific reason or could it be other comorbidities, such as in China, for example, more men than women are smokers. And what I would like to see actually would be to differentiate, for instance, men and women among non-smokers and take away that confounding confounding of smoking and see if we still see a differentiation between them. We haven't seen those type of data yet, unfortunately. Recovered, almost 90%, 87%. On the other hand, we had a death rate of around 4%, 3,245 cases out of, at this time, 80,000 cases, as of March 19. Severity, probably around 80% of people are going to have very mild cases of the disease. Severe cases around 14%, and critical cases up to around 5% of the disease itself. But we do see a gradient when it comes to age. If you look at patients over the age of 60, you suddenly see an increase in the death rate. 60-69 here were 3.6%. On the other hand, 70 to 79 was 8%, and over 80 is almost 15%. The good news is that there are patients that are very old, that still survive. The latest case we heard of was an individual with an age of 104 that actually contracted disease and recovered and could actually leave the hospital. Another interesting curiosity that we see here is the fatality rate association with different type of comorbidities. And what we see here in this slide, again, this is from the cohort in China, is that patients with cardiovascular disease fared much worse than individuals with diabetes, chronic respiratory disease, high blood pressure, and cancer. And it could be reasons for this, and I'm going to go into a little bit more details about this in another couple of slides. I mentioned before that testing is extremely important, and the reason for testing being important is that it's a vital part of understanding the scale of the outbreak and how it's evolving, how it's progressing. We should test every suspected case. If they're positive, isolate those cases and find out who they've been in contact with, tracing those individuals within 2 days before they develop signs or symptoms, and test those individuals. And large-scale testing allows health services to quickly identify who has the disease and arrange for them to receive the care needed, as well as isolating known cases that prevents them from coming in contact with others and slow the rate of their progression. But testings are not 100% reliable, and there are many reasons why tests might fail. The patient may be in an early stage of disease with a viral load that is too low to be detected. The patient may have no major respiratory symptoms, so there could be a little detectable virus in the patient's throat and nose, meaning the sample could not be enough. There may have been a problem with the sampling collection, meaning there was very little sample to test. There may have been poor handling or shipping of samples or test materials, or there may have been technical issue inherent in the test, for instance, virus mutation. The WHO, the World Health Organization, suggests that these issues should be taken into account when we test individuals, and the test should be carried out several times on the same individuals. Around a week ago, late March, Abbott's Diagnostic came out with a point-of-care test device. This little machine that you see here in front of you weighs around 3 kilos, 6.6 pounds, and it enables you actually to get positive test results within 5 to 15 minutes, 5% for positive results, up to 13 minutes actually for a negative result. What is this based on? Well, on the right-hand side, it's a graphic provided by Abbott to show how the device is working. On the left-hand side, I have highlighted the text that is associated with this graphic. So number one, an upper respiratory tract swab collects a mucus sample for testing. Two, the sample is mixed with reagents which break open the virus and release the genetic material, the viral RNA. The reagents recognize a unique section of the coronavirus genome while ignoring other viruses and similar strains. The virus genome is replicated from a few targets, molecules up to a billion, making the virus more detectable. And this is really the polymerase chain reaction that we talked about later on, how you take one single genome and then you replicate it, that polymerase chain reaction, the replication of the virus. Abbott's molecular test then provides a result to the healthcare workers. Now, there are several other tests that are coming very soon, and there's a long list here. I'm just put down a couple of here that we know today, and many of them are getting at what we call an experimental approval for use, meaning they're not approved 100%, but they are experimental use approval, meaning you can use them for specific individuals during specific cases now during the pandemic, but they don't have full approval yet of the FDA, and it's probably similar things happening in other countries as well, obviously. Another thing that people talk a lot about are antibodies. Should we do antibody testing? Well, antibody testing can be very helpful for a lot of different reasons. It can verify that vaccines are working as intended during clinical trials. It can be used in contact tracing weeks or longer after a suspected individual have been infected. Probably it's the most important current use en masse is to help inform public policies, meaning we can probably figure out how many people have been exposed, even though they are asymptomatic because they have developed antibodies. They were exposed, developed antibodies, and we can test for that. And also, antibodies obviously reveal evidence of a previous infection, which means we can be able to trace individuals that have been exposed to those individuals that were infected, and then maybe enhance our tracing of other cases that are infected. So what are the major questions and answers that people are concerned about today? Well, first of all, let's look at trusted and reliable information and resources, and every country have their own. In the United States, we look at a lot at the Center for Disease Control and Prevention, MMWR, which is a publication coming out of CDC, or Center for Disease Control Prevention, WHO, the World Health Organization, have websites, and then you have a lot of different journals: New England Journal of Medicine, British Medical Journal, Journal of Medical Association, the Lancet, and so on and so forth. They are specific resource centers, specific centers where you can access information. Now, the good news is that all publishers, the vast majority of scientific biomedical journals today, have enabled an open access to all of this information, meaning if any article is published on the coronavirus, on COVID-19, it immediately is accessible to anyone. You don't need a subscription at all. Not only that, but there are also other places. This is a place at the National Library of Medicine, NLM, that you see on the bottom here, that actually is a hub where they accumulate, become a repository for all the articles published on COVID-19. And this is a great place to go and look at these articles, but it's overwhelming. At the present time, you have one article, more than one article published every hour. But there's a concern here with this rapid progression of these articles coming out. Many of these articles are actually posted on different websites. This is something called Med Archive. It's a site that is supported by British Medical Journal, Yale University, Cold Spring Harbor Laboratory, and so on and so forth. And at this website, individuals can upload their articles. Now, a lot of the information, especially those that have some explosive new information, are then picked up by news agency, and then everyone knows about them. But be aware, that many of these articles have not been peer-reviewed. They're preliminary reports and not peer-reviewed. So there we have our ability, hopefully, the way we are trained, that we can look at this information and say, wait a second, it's a preliminary report, it's not sure yet, it hasn't been validated, we're not clear how that's going to affect anyone clinically or in practice and so on and so forth. So we have to be very, very careful with all this information that's being spewed out today by both the medical profession, our own profession, unfortunately, and the media as well. So be very, very careful with and be able to differentiate between information and misinformation. So let me just deal with a couple of questions that usually come up. When is a person not infectious? So person not infectious, meaning they have been infected already, meaning when are they not contagious? The patient is free from fever without the use of fever-reducing medications. The patient is no longer showing signs or symptoms, including cough. The patient tested negative on at least 2 consecutive respiratory specimens collected at least 24 hours apart. Now, these are individuals that have already been infected. Could someone spread the disease before they show signs and symptoms? And the answer is yes. We know much more today than we did only a couple of days ago. This is a New England Journal of Medicine article that came out on March 26. German researcher here looked at 126 people that came from Wuhan to Frankfurt, and they screened these individuals for the virus. And 114 of these individuals had no signs or symptoms. Yet 2 of those individuals were later found to have evidence of the virus in throat swabs. So here you had asymptomatic individuals that still had positive specimens coming out of the throat swabs. And these individuals didn't develop any signs or symptoms later on either. Another case, but it was published actually earlier, was a case of a businessman in Germany who had been exposed to a business colleague that later on went back to China. Now, she and this business man from Germany, they had been in a discussion in an office, and although she was asymptomatic, this individual, this businessman from Germany, German businessman, developed actually signs and symptoms later on. Now, this individual were in contact with other individuals as well during his asymptomatic period, and he also infected other individuals. So here's more proof that asymptomatic individuals can actually transmit a disease. MMWR 2-3 days ago, on April 1st, actually came out with a study on 7 different clusters of individuals in Singapore, where they look, 7 different clusters of cases in Singapore where patients were pre-symptomatic, yet they transmitted the disease very likely. So today, the thought process today is at least that yes, even if you're not symptomatic, if you have been exposed to the virus, you may actually be able to transmit a disease. A very sad case was actually reported in Los Angeles Times on March 29th. Here you had 60 individuals that participated in choir practice. They made sure that they didn't have any contact with handshaking or hugging or kissing or anything. The only thing they did was they practiced for 2.5 hours singing. Unfortunately, 3 weeks later, 45 out of these 60 individuals were diagnosed with COVID-19, and unfortunately, 3 of them have been hospitalized and 2 were dead already on March 29th. So this is another indication or suggestion that even being in contact, long contact, 2.5 hours, with people who are exhaling, but more than just exhaling, they are singing, could actually transmit the disease. But obviously, we'll find out more about the modes, exact modes, and effectiveness of, or efficiency, how this disease is going to be transmitted. So should we wear a mask? Different countries have different recommendations. This is an article that was actually published in The Lancet on March 20th, looking at that time, March 20th, at what were the practices of wearing masks in different countries. WHO at that time, if you're healthy, you only need to wear a mask if you're taking care of a person suspected of COVID. In China, they divided patients into moderate risk of infection, and those individuals should use surgical disposable masks for medical use. Low risk of infection, disposable mask for medical use, and then low risk, do not wear a mask at all. So this is how the recommendation came out in China, and those are individuals, and Chinese authorities obviously have most experience with, at that time at least, had most experience with COVID-infected individuals. Hong Kong, wear a surgical mask when taking public transport or staying in crowded places, otherwise not. Singapore, wear a mask if you have respiratory symptoms. Japan, it might help avoid catching droplets emitted from others, but if you are in an open air environment, the use of face mask is not very efficient. In the US, the CDC at that time did not recommend that people who are well wear a mask. So this again was reported on March 20th, today, April 3rd. CDC has now changed their recommendation and now recommend that anyone and everyone outside or in contact with anyone else should actually wear a face mask. And we're not talking about respirators, we're talking about surgical masks. In the UK, the statement is very little evidence of widespread benefit for using masks. And in Germany, wearing a mask in situation it is not recommended to do so because it creates a false sense of security. And also, one of the other concerns is obviously that if we don't have enough of these masks, we are going to actually diminish the ability, or we're not going to enable individuals that actually treat these patients to get the mask that they need. Is it safe to use NSAIDs? Where is this coming from? Well, it's based on, at least in part, on a recent article published in Lancet that hypothesized that NSAID could increase or upregulate angiotensin-converting enzyme 2. So we know that the severe acute respiratory syndrome coronavirus, such as SARS-CoV-1 and SARS-CoV-2, bind to the target through the ACE2, through the angiotensin-converting enzyme number 2. And it's present in the epithelial cell throughout the body, including the lungs. So people are saying, well, if that's the case, an NSAID could actually theoretically at least increase or upregulate ACE2, should we avoid using NSAIDs because of that reason? Again, different in different countries. In France, as well as in the UK, there are recommendations not to use NSAIDs. In the United States, at least as of today, there are no recommendation not to use NSAIDs, but if you should use NSAID, it probably will be prudent to use naproxen sodium and ibuprofen. Now, this again is an example of an article that was published very quickly without sufficient peer review, was picked up by authorities and said, okay, if this is the case, if this could be the case, we need to come out with recommendations. Obviously, this type of information need to be validated scientifically before we can put in real recommendations. But this is the rationale behind some countries suggesting that we shouldn't use NSAIDs. Are there any ongoing trials to treat COVID? Yes, there are. At the present time, more than 69 drugs, as well as plasma, obviously, are being used, or plasma from individuals that have recovered from COVID are being used in order to treat COVID patients. WHO actually launched on March 22nd a large trial called Solidarity. In this trial, they actually used a drug combo that includes medications that were used against HIV or are used against HIV, such as ritonavir or lopinavir, with or without interferon alpha. A malaria treatment first tested during World War II, which is chloroquine or hydroxychloroquine, and a new antiviral whose promise against Ebola fizzled out very quickly. And now they're trying this medication against patients with COVID instead. These medications, they use specific areas when it comes to the virus itself. For instance, the antibody detachment. Some other medications prevent endocytosis, translation, proteolysis, or RNA replications. Answers to what I call facts in quotation marks, meaning misinformation. Well, there are a lot of this misinformation, unfortunately, out there. SARS-CoV-2 cannot be transmitted in areas with hot and humid climates. We don't really know, but most probably it does not mitigate, meaning most probably the climate does not mitigate progression of disease, which goes both for cold weather and hot weather. The humidity may actually have some impact on transmission of disease, but we don't know enough about it yet. Taking a hot bath prevent COVID-19? No, it does not. SARS-CoV-2 can be transmitted through mosquito bites. No, it can probably not be it cannot be transmitted that way. Hand dryers are effective in killing SARS-CoV-2. No, there's no evidence for that. Spraying alcohol or chlorine all over the body will kill SARS-CoV-2. No, there's no evidence for that either. Vaccines against pneumonia, such as pneumococcal vaccine or Haemophilus influenza vaccine, provide protection against the coronavirus. No, there's no evidence for that either. There's evidence that regular rinsing the nose with saline has protected people from infection with this new coronavirus. No, there's no evidence for that either. Antibiotics should be used as a means of prevention or treatment of COVID-19. No, antibiotics, they work against bacterial infection, not viral infection, obviously. Now, they could be effective when it comes to comorbidities, but that's about it. There are already specific medicines recommended to prevent or treat COVID-19. No, there are none. There's a vaccine for COVID-19. No, there's no vaccines available yet. There's evidence from the current outbreak that eating garlic has protected people from SARS-CoV-2. No, there's no evidence for that either. You can protect yourself from COVID-19 by swallowing or gargling with bleach, taking acetic acid, steroids, or herbs, or using essential oils, salt water, ethanol, other substances. No, there's no evidence for that. And the virus was deliberately created or released by people? No, there's absolutely no evidence of that either. And lastly, ordering or buying products shipped from China will make a person ill? No, there's no evidence for that either. Unfortunately, there are a lot of websites that promulgate a lot of false information. And there are an enormous amount of these websites in the United States, but just because they're in the United States doesn't mean that anyone outside the United States cannot access them. So these are just some of the websites that I found that emanates from the United States, and they are really, some of the information out there is really scary, and there are really more conspiratory ideation, meaning there's conspiracy theories that are being promulgated on many of these websites, unfortunately. There are also these websites, obviously, in the United Kingdom, France, Italy, Germany, and other countries as well. There are also scams going on out there, unfortunately. This is an email I received where I could download a free ebook on COVID-19. Now you can see two things here that you should be aware of. Number one, coronavirus is corona dash virus. That's not the way coronavirus is being spelled, specifically not by WHO. And then you have to download a zip file, and obviously you should be very careful download any type of zip files. What about dental care? Well, the Centers for Medicare and Medicaid Services in the United States is a federal agency within the United States Department of Health and Human Services that administers Medicare programs and Medicaid, and they usually set the quality of standards in the United States, and every country probably have something very similar. But on March 15th, CMS came out with the following statement. Dental procedures use PPE and have one of the highest risks of transmission due to those close proximity of the healthcare provider to the patient. To reduce the risk of spread and to preserve PPE, we are recommending that all non-essential dental exams and procedures be postponed until further notice. And this is a recommendation, I think, that are now very similar in many other countries as well, meaning only provide urgent and emergency care, no elective dental care to patients. Center for Disease Control here in the United States are coming out with specific recommendations of dental settings, and other countries will have their own specific guidelines, as well as regions, as well as WHO. So My suggestion is that you look at what you have in your countries, in your areas, wherever you may practice, as well as go back and maybe look at the CDC guidelines as a baseline, or where you can actually promulgate your own guidelines for dental settings. The American Dental Association very early on came out and differentiated between dental emergencies and dental urgencies. What they said was the following: dental emergencies are potentially life-threatening and require immediate treatment to stop ongoing tissue bleeding, alleviate severe pain, infection. They include uncontrolled bleeding, cellulitis, or diffuse soft tissue bacteria infection with intraoral or extraoral swelling that potentially compromise the patient's airway. Urgent care, on the other hand, are the normal type of emergencies that we see in a dental setting. Patients coming in with pain, patients coming in with a little bit more bleeding. There could be a pulp inflammation, pericoronitis, third molar pain, and so on and so forth. So at least in the United States today, the recommendation is only dental urgent care and emergency care, no elective dental care. Disinfections is something that we need to use when we have treated these patients. The question is disinfections enough? And the answer today at least is yes. There are disinfecting areas from where you have treated a patient is enough, because these droplets, they fall to the ground fairly quickly, and you can then disinfect the area surrounding the patient, and you can then seat another patient. As far as we know today at least, there is no virus that is suspended in the air for hours, meaning as far as we know at least today, there is no virus that is suspended in the air for hours, which would prevent you from treating the next patients after you disinfected the operatory surrounding the areas where you treated the patient. What type of disinfectants can be used? There are a lot of lists. This is from the United States, from the Environmental Protection Agency, or EPA. It's a long list of different type of medications here, and again, different countries probably have their own lists, but this again is just one resource that you can look at. So in the end, what is needed and what do we need to do? Well, first of all, we need to identify signs and symptoms of disease. We need to be able to test individuals in order to get a better handle on this pandemic. We need to do rigorous contact tracing, find individuals who are infected. Maybe they are having fevers, or maybe they're even asymptomatic. Isolate and or quarantine in order to stop discrete outbreaks. Social distancing, it's something that seems to be working very well. Travel restrictions, we have today both international and domestic travel restrictions, and these restrictions are going to change during the progression of disease, obviously. Lockdown, shelter in place, as I mentioned, more than 50% of the world population today is under lockdown, most probably. We need to be able to increase the mass production of personal protective equipment. We need to be able to retrofit hospitals. We need to get more ICUs, intensive care units, more ventilators, and other equipment that is needed to treat these critically ill patients. Unfortunately, there are many hospitals now that prioritize treatment. They make decisions on who should get care and who shouldn't, because they don't have enough ICUs or ventilators for every patient. And we need to obviously focus on development of therapeutic or preventive medication. But probably the best advice I can give you is let the expert do the talking, especially when it comes to medical claims that are not supported by solid evidence. And with that, I thank you for your attention, and hopefully I was able to clarify some of the concepts that you hear, as well as answer some of the pertinent questions that you might have.